Hi, it's my pleasure to be part of the Breast Cancer Update Dubai presenting Fujifilm. I'm going to take you through an artificial intelligence tour to unveil the mystery of mammogram. First, I will talk about the AI that's not an ordinary computer. It's actually a smart computer programs that imitate the biological neurons in the human brain and so could mimic the human brain behavior. AI is no longer a figment of imagination for the science fiction authors. Actually, the concept of development and the implantation of AI and machine learning for mammography has now been established. The mammograms are recaptured with Lunit Insight MMG, which is a FDA-approved diagnostic support tool, AI software. The AI provides location information of the detected lesions on the mammogram in a form of what is called a qualitative estimate for the magnitude of the abnormality. For instance, this breast is extremely dense, full of glandular tissue. It's very difficult for even the expert radiologist to find out the abnormality. It may take up to 10 to 15 minutes to say it's negative or not. Yet with the AI scanning, it's so much obvious that we are having here a lesion in the deep central and upper quadrant of the left breast with intense red color hue. Then to more clarification of this magnitude, there is a numerical estimation given by the artificial intelligence about the confidence for suspicion of malignancy, which have a range of evaluation with less than 2% for the definitely non-cancer and going through down up to 100% for the definite cancer lesions. So the first question to ask whether the AI is only for detection of the cancer or it could be used for diagnosis and sorting of the lesions between benign and malignant categories. For example, this case came for a screening mammogram. It is the breast of a choice for the radiologist because it's extremely fatty. And if there is any abnormality there, it would be easily distinguished. So for our first site, it was normal. It's the clear breast. Then when scanned by the AI, was an alarm here in the upper outer quadrant of the right breast, telling us that there is a suspicion of carcinoma with a confidence that it is cancer with about 92%. On the ultrasound targeted with the AI scanning, yes, actually there was a 4 millimeter cancer-looking mass, and the nodes were also a little bit indeterminate. So by the ultrasound, now the patient turned from being normal to probably malignant. So triggered by the AI that suggested a probably cancer lesion and the biopsy was taken, it was an invasive ductal carcinoma grade 2 and it's a true positive case. Another screening mammogram in the 60 years old patient, it is the breast here in this time is full of glandular tissue, and it could be very difficult to get through the breast at the instant. Yet with meticulously scanning the breast, there was here the area of asymmetry and subtle distortion, and it was given a probably malignant lesion. By the AI scanning, there was confirmation to our presume on the mammogram. The ultrasound also say it's likely malignant with the speculation outlining the lesion and the pathological lymph nodes in the axilla. Doing a contrast-based study, it's better when we're dealing with malignant lesions because it may give us an impression about the extent of the disease, the other minions, the multiplicality, the multicentricity, and if there is a contralateral disease. According to this study, the index mass here is the one obvious, the breast given us a nodular background contrast uptake, and so it's not pretty sure about the other lesions in relation to the index mass or not. Going through the AI scanning, we can see here that the AI, in addition to this index mass, it has demarcated the nearby area of extent to be involved in the disease. And so we may have the impression that the eye is not only for the detection, not only for the diagnosis, but also we may consider it through the color hue extent and the outline demarcation to be a tool to determine what's called the local staging of the obvious carcinomas. Another case, also for screening mammogram, the breast shows a little bit heterogeneous scattered densities. And there was here in the upper outer quadrant of the left breast, the area of speculation with some clustered calcification within. So it's probably malignant. This time the eye is not matching with the mammograms, telling us that it's possibly non-cancer with a low percentage of 38%. So we went to the ultrasound, another tool to see where to go, and the ultrasound goes more with the mammogram. It tells us that the lesion is heterogeneous, and there is a speculation here all through the outline of the lesion. The nodes was a little bit not going to one side or another. Sometimes it's non-specific, and the other time it shows cortical thickening. To get to the contrast-based studies, in order to give us more idea where to go with the likely malignant appearance with the mammogram, or go with the suspicion, go with suspicion, or may consider the AI of dealing with a benign-looking lesion, however, it have a suspicious morphology. So on the contrast-based study, the lesion showed more indistinction of the outline and heterogeneous texture. It confirmed it more it's to be likely malignant rather than a benign lesion. On biopsy, it was a true negative. It was an intraductal papilloma and a typical ductal hyperplasia. So AI going through the pixels of the image could help us to see what the usual sight of the human beings cannot see. Sometimes lesions are suspicious looking, however, it's of benign pathology, and as this case. So when we get the suspicion looking breast lesion and the artificial intelligence scanning give us a low scoring percentage, we may consider the lesion for a follow-up rather than going on to the biopsy and subject the patient of unnecessary trauma. Another condition or another idea, can AI affect the Barbads category of the digital mammogram and hence its capabilities for the diagnosis and misdiagnosis? Well, in this case, it's very obvious that abnormality in the left breast, the lesion is so much large and having a circumscribed outline, we may give it a probably benign category. We having these areas here surrounding the mass and some dermal thickening, and we may consider that we could be dealing with a large mass, so it have some reaction surrounding it. It could be purely solid or could be an abscess, could be an inflammatory condition, complex mass. So it's better to go for the ultrasound, start to get more a precise Barrett's category. Here on the ultrasound, it's a purely solid lesion. Sometimes some areas of it are heterogeneous, yet it's so much circumscribed, and the nodes, it's more likely non-specific. So again, with the ultrasound, we are dealing with a probably benign lesion when we consider the 5 lobe epithelial tumors category, whether phylloides or large adenomas or maybe even Bush. But the AI is not telling these informations. It's telling us it's definitely a cancer, giving it a scoring of 98% and very intense red color hue. Contrast-based study, this time goes with the AI and tells us that it's likely malignant. The features, descriptive morphology was with the malignancy more likely. The lesion showing a central area breaking down, it's heterogeneous texture of contrast uptake, or more or less we may say RM enhancement. The area surrounding the lesion, which was not a tissue reaction, it actually two minions here. It's satellite related to the mass, which was also involvement in the demarcation of the AI. So when we go through the BIRADS, we could find that the AI give us the virus category of the contrast-based study, and this was coinciding with the pathology that revealed a micropapillary carcinoma. The AI algorithm through the image level fine-tuning, so can help us to recognize some tumors that is benign looking, circumscribed, mimicking the benign masses, although they are very aggressive types of carcinoma, and moreover could determine its actual extent. Another case that apparently appears to be normal on the first sight. The AI tells us no, there is a lesion here in the upper outer quadrant of the right breast, although the percentage is midway, it's possibly non-cancer. Going again to the mammogram, the lesion is here. It's a focal area of speculation that was not that obvious on the first sight, but in the second sight triggered by the AI, although the AI gives us a scoring percentage, which is rather not high, but morphology basis, it's suspicious and it's probably malignant by the mammogram. On the ultrasound, there is more confirmation that the lesion is suspicious with the speculation here and triggered by feeding vessel. The nodes were non-specific. On biopsy, it was sclerosing adenosis, and it's a type of a benign pathology that have a malignant-looking features and suspicious features and mimic carcinomas. So in case of suspicious-looking lesion, where the AI gives us low scoring and very cold light color hue, where the biopsy was benign, we may not consider the rebiopsy, because in such case, after the biopsy of being sclerosing adenosis, the pathologists will give us the bowl and said, so what is the idea of the radiologist? And the surgeon will do so. If you consider it still suspicious, we are going to do the rebiopsy. But yet with the coinciding of the AI and the scoring percentage, the extent of the lesion, we could be evident about our biopsy results and said, no, it's sclerosing adenosis. It had just a suspicious looking features, and we will not do a rebiopsy. So I guess the AI does the work of hundreds of clinicians, and the algorithm help us to get the accurate evaluation by the mammogram and could spare the patient of the unnecessary biopsies. But the question that comes next, may AI miss the abnormalities if there is dense breast and overlapped with some glandular tissue overlying the lesions? This case is a 50-year-old female. It has the palpable mass in the upper outer quadrant of the right breast, and it's very obvious we are dealing with a carcinoma. And in addition, we have here area of asymmetry and skin thickening. It could be an associated inflammatory condition or changes from the carcinoma, or could be part of the disease. The eye tells us that there is only this unifocal mass, and there is no triggering of this retroareolar area or the skin, and also scan the contralateral side and tells us it's negative case on the left side. The contrast enhanced mammogram goes with the AI. Yes, it's a unifocal mass, and the changes here, the retroareolar with the dermal technique, it was associated inflammatory changes to the carcinoma, but also spotted this lesion here in the right breast retroareolar that was not mentioned or was not triggered by the AI. Going again to the mammogram, it's here, it was masked by the glandular tissue, overlapped this lesion, and AI gives the left breast a low scoring, abnormality scoring percentage. So it's missed with the AI, or it's neglected by the AI, and it's telling us that it's less than 10% abnormality scoring. Well, this is not obvious to us on the in the preliminary practice. This is what not that's clear what the AI neglected or the AI missed it from its conception. So we pass through other cases to see if the eye misses the lesions or not. And this case, we have in clear area of asymmetry and some concavity to tell us that the underlying area, it could be having a lesion. Scan by eye, and there is here the 11% scoring of the left breast. On the ultrasound, which just simple cysts correlating with this area of asymmetry. On the contrast enhanced mammogram, there was no demarcation of this area, only the glandular tissue surrounding the cyst. And so from this, we may say that AI didn't miss the lesion. It's only giving her the suggestion for follow-up, and it's not, according to the category of the eye, it's not cancer or definitely not cancer. Another case to tell us where to go. Actually, this lesion is so much obvious. The breast is mainly scattered fibroglandular tissue, and the mass is in the fatty component of the breast. It's so much obvious. So it's probably benign lesion for the mammogram, and for the artificial intelligence, I guess it's so much obvious. It's in the fatty area of the breast. Here again, there is no marking, and the left breast was given low. On the ultrasound, the mass have exhibit some suspicious features of increased vascularity and some border irregularities, and was upgraded to probably malignant. A biopsy was taken, and it was turned out to be just left adenoma. So when we find that the eye scan mammogram, there is no superposition of a color hue, and there is no evident abnormality scoring percentage, this may indicate that we are dealing with a low 10% suspicion of malignancy, or in other words, definitely non-cancer, and doesn't mean that the eye is telling you this is a normal mammogram. So please, when you get a dense breast, do ultrasound, because sometimes there is some benign lesions there in the breast, and the eye is considered not definitely cancer, and so the breast will not have any scoring or color hue demarcation. These two cases, we have both lesion gave the upper limit abnormality for a scoring range to the possibly cancer. The one to the right side is abnormality scoring 70%, and the one to the left side is 61%. And we can go through to analyze these two cases. The lesion of this case number 9 on the ultrasound was having the malignant features with irregularity of the outline, the increased vascularity. And it was, yes, invasive ductal carcinoma grade 3. The case number 10, it's looks fishy on the mammogram, yes, with here the lymph node, intramammary lymph node enlarged, but on the ultrasound, it was just a complicated cystic lesion. It's an abscess, and on biopsy, it was granulomatous mastitis. So we can see that sometimes the eye give an overlap in its abnormality scoring percentage and give the impression of possibly cancer, although sometimes it's benign or it's malignant because it's more or less, there is estimation of the morphology descriptors from the mammogram. So when we find this overlap of suspicious lesions and there is overlap with the AI, it's better to give the ultrasound a chance to support your findings. And so to be fair with the artificial intelligence, actually it scores abnormalities. So according to the scoring of the abnormalities, we could find this track to be supported by the mammogram findings, to be needs more confirmation ultrasound, or if we are going to need further evaluation by contrast-based studies. We tried to perform a study in Cairo University about if we can artificial intelligence aiding the mammogram could replace the ultrasound, and actually we find out that it could support the mammogram and the ultrasound in the diagnostic basis, and yes, it could be a supporter for the mammogram in case you are doing screening mammogram. It provided a median score of more than 88% for malignant breast lesion and a low score of less than 40% for the definitely benign lesions, with a resultant cutoff value of 59% abnormality scoring to distinguish between benign and malignant breast lesions. And on going through these statistical indices, it provided us with a near specificity and accuracy to the combined evaluation of the digital mammogram with the breast ultrasound. There was a famous movie named Shawshank Redemption in 1994. It was about the experience of two prisoners in prison and how sometimes we build our own walls, our own prison is inside us. This is the way with us sometimes radiologists, when we go through the mammogram and find ourselves finding paths through templates, there's no way out. There is no way for the innovation or a new options. However, we may do for ourselves what is called the institutionalization, and instead of getting more elaborated and more out-of-the-box ideas. AI now is our chance, our glow, to go for another path and give our patient the service. We shouldn't look for it as Armageddon or as the eradicator of the breast radiologist. On the contrary, it is our second eye. It's actually unbiased cooperator and even a decision participant that can get our patient the effective interpretation and consequently the professional management plan. However, for the best performance, it has to be strengthened by the continuous monitoring and proper supervision. This 4-image mammogram view has been scanned with artificial intelligence, and it is the first reader in our radiology department. It gives us targeted location of the abnormality in the form of a heat map, abnormality scoring percentage for the suspicion of malignancy, and even demarcation outline of the actual disease extent. It only requires validation, and this is so much easy. Only we need further evaluation by the senior radiologist. Thank you so much.
Thank you very much, Professor Sahar Mansour. Very nice lecture. Very happy to see you in direct for now. And maybe we have some question. Nagla? So Nagla, I have a question for you, or maybe an observation.
She's my friend. She can see me. Where is the camera? Sahar is my friend. She's a colleague in Cairo University.
Okay. She's there. You can speak to her. You can speak to her.
Actually, I have a comment, not a question. She's my friend. She's one of our rising stars in the department. She's very experienced in MRI. I have a comment for you, Sahar. I'm happy to see you. It was a surprise. I have a question for Sahar. Do artificial intelligence perform, where do you place the artificial intelligence? For my opinion, if you agree or not, I know you are experienced in this, I place the artificial intelligence above the performance of the junior radiologist and below the performance of the senior radiologist. Do you agree?
Yes, actually, I find your phrases is the perfect that could describe what's the place of the artificial intelligence. It scans the mammogram and tell us where the abnormality. If I'm having a junior radiologist with it, it could drag him down, and a lot of faults could be applied during the daily work. But it needs the monitoring of the expert supervision by the senior radiologist, and this would uplift our performance high up. Because there is a lot of could be not about just missing the carcinoma, it's about the discrimination between different lesions. The eye could sometimes trigger a lesion and tell us that the hue is not that much intense, and we could give the patient a chance for follow-up. Or sometimes a lesion that appears apparently to be very benign looking and more or less apparently glandular tissue, and give it a very high hue and urges for the biopsy or to trigger it with the wire localization and excision biopsy, especially the calcification. Sometimes there is this punctate calcification that's not that clustered or gathered, and you get the dilemma about it's whether to go for the follow-up or to do the biopsy, or it's necessary to face the patient with interventional procedure. But with the abnormality scoring and the targeted hue, it's easily to get to which side is perfect for the patient, and which give a good credibility for even us, the radiologists, in the handling our patients.
Yes.
And maybe just you speak about IA in characterization. I'm agree with you, Nagla. Maybe in characterization, the assessment of a lesion, maybe an expert should be better than an EA. But what is very interesting for me in the EA is the detection side. Because in the daily practice, when you work, sometimes you're tired. Yeah. Something you will detect on the morning, maybe you will not detect in the evening because you have many things to do. And what's very interesting with the AA, it's never tired. It's always like your friends, like a friend who is with you. And give the chance to have an augmented radiologist. It's not IA. The IA become the radiologist, an augmented radiologist. It's not here to replace it.
Instead of the double reading.
Exactly, but it's here to help him. And there is a two-way. It was very interesting. The scoring of the device. The scoring is very interesting. In that way, you're right. An image. You saw the mastosis, the granular matosis, which is a BI-RAD 5. Of course, the device we recognize the image as a BI-RAD 5, and it's a benign lesion, like in the real life, it's the same. But and the two arms of the AA, detection and characterization. I think for now in France, the devices that we use are more involved in detection than in characterization. But you have another company here that are working on the scoring as well as Fuji like this. So it's in progress. It's very interesting. And of course, we have to see that like a friend, like a help. It's helping us, and not to replace the radiologist. I don't think so on my part.
It will be helpful with us as well. Then, as I told you before, the number of experienced radiologists could not exceed all over the country 50.
Yes, of course.
So it will be helpful.
And
a comment about the characterizations. Yes. Actually, sometimes there is overlap in the characterization between the benign and malignant. We may face it on the mammogram and ultrasound, especially the mammogram. Mammogram sometimes track us to the suspicious lesions, and on the ultrasound, you could find that you are dealing with just a complicated cyst or an inflammatory process. As I said before in the lecture, that sometimes it's hyperplasia or epitheliosis or the physiological changes in the lady breast, because it's a secretory organ and is subjected daily over daily basis to different changes in response to the hormones. The scoring of the AI sometimes give us where to go and lift it to a shore, which is very safe shore. It's about not to overuse the biopsies. Now with the scoring of the AI and the morphology with the mammogram, we could know which patient that will be subjected to ultrasound, which will go for the biopsy, and which we are going to subject for follow-up. It's more or less discriminate, and not just about the detection. It also could help us in order to reveal the mystery of the characterization that sometimes we subjected from the overwork in our daily work.
Yeah, so we understand that. So it's very interesting, and it's the next future, and for you the present. So, and so any other questions or observations? Yes. Come here to the microphone. Yes, come back to the microphone. Yes. I have a question from our colleague from South Africa. It's working. It's working. It's okay.
Thank you. So I'm one of the fan of AI, and then I just wanted to know the software used for this particular study that she mentioned. Was he a supervised or unsupervised software? And then the study that she showed us, unfortunately, was a bit quick. We saw just one page. I want to make sure if in the study they managed to look at the accuracy of the AI, and then if there was any portion of either comparison or correlation with the human side, and then to see which data we have there. Thank you.
Sahar, do you have the answer to this question?
Yes, I heard the question. First, about the AI, we use in the study L-Unit. It's an L-Unit inside MMG software. It's South Korean AI algorithm that is FDA approved for the mammography since 2019. The L-Unit uses the AI in a form of two stages. Stage number one is pixel to pixel level, which is similar likewise to the CAD. It's detects the increased density, the differential areas of symmetry in between the two breasts. And then another stage is about the image fine tuning, where it goes for the distortion, the different calcification size and densities, and the abnormal densities within the two breasts. L-Unit doesn't only detect the lesions, it actually apply abnormality scoring percentage, as I said earlier, about the accumulation of the suspicion, and moreover, the density of the breast as well. In the study that I've mentioned in the lecture, actually we compared the human performance regarding the mammogram and ultrasound with the mammogram and AI performance. And we have reached that specificity of both of them were comparable. For the mammogram and ultrasound, it was about 92%, and for the AI and the mammogram, it was 91.6%, which is a very comparable specificity. And in the accuracy, both of them were about 95 to 96%. And that's why the name of the study was how could we replace the ultrasound? But actually, on the basis of the clinical basis, we found that some cases it could be easily targeted by the ultrasound, and the characterization of the lesion could get us to the pathology with no need to the biopsy. But the AI sometimes be deceived with the mammogram features that overlap between the inflammatory and the cancer in many cases. So that's why at the end of the study, although the AI gives us a very high specificity and accuracy, we still need the ultrasound, because sometimes characterization may get us to the, what I can say, the accurate diagnosis. It gives us the impression if I'm dealing with the abscess with the vat necrosis or a complicated cyst that could overlap. And that's why I put the last two cases, case number 9 and case number 10, and said that sometimes I got the overlap from the morphology descriptors of the mammogram, and the ultrasound could reveal the case. So for the best performance, we may use the mammogram, the ultrasound, and the eye all together hand in hand to get the best outcome for the patient in case of the diagnostic setting.
Can you can you explain again for the junior radiologists who are online with us the difference between CAD reading and artificial intelligence? You mentioned in your answer, but I want you to say it clear again.
Reading, it's not a smart computers. It's only detect areas of increased density different from the breast. Any areas of differential contrast from the rest of the breast, that's the area that demarcated. And this gives us a lot of false positive cases. And sometimes areas of asymmetrical glandular tissue or some physiological changes within the breast could be scored, or otherwise not scored. It could be marketed by the computer. AI algorithm, it thinks like our brain. There is a neural network, a deep learning that through the cases that passes every day could neglect some cases, as we can see some other cases containing a masses. This is very obvious in the fatty part of the breast, and but it didn't give it a score or give it a marcation by color hue, because according to the AI that thinks at having a neural neurons like the neurons in our minds, he knows very well that this demarcation, the mass is low density, is circumscribed, is in the plane with the breast. It doesn't have an additional internal calcification. So it's according to it, it's having a low probability of being a cancer. And so there is no scoring for the lesion. If we are going to scan the same breast by CAD, it will perform a demarcation on the lesion and may drift us to do unnecessary biopsy for the patient.